Our next section is going to be some talks on improving care and resources and kind of moving along the journey. So we talked a little bit about science and surgery. And next, I'd like to introduce Dr. Stephanie Cham. Dr. Cham also recently joined our faculty in the division as an assistant professor. She is also doing a women's health research scholarship program. And Dr. Cham was a resident at Columbia and completed her fellowship in Boston at Brigham and Women's and the Dana-Farber Cancer Center. She's going to be speaking us today on her research interest, which is improving care for the frail and elderly population with gynecologic cancer. Dr. Cham.
Thank you guys so much for having me and for letting me share something that I'm passionate about, and hopefully you all will learn a little bit more and find some interest in this topic as well. So what I'll be talking about is frailty and its impact on the management of gynecologic cancers. And just as an overview, we'll be talking about really defining what frailty means and who it affects. And we'll be exploring the impact of frailty and briefly talking about methods to support frail patients. And so I think one of the first most important questions we really have to ask ourselves is, what does frailty mean? And these are two nice pictures that I think really helped us understand and kind of depict what frailty means and how it affects our patients. We really think of it as a cyclical state of diminished physiologic reserve, resulting in a decreased adaptive capacity and resilience to stressors. And so one of the kind of analogies that I often see used is kind of like a spring system here. And as our patients go from fit to pre-frail to frail, they eventually have a poor adaptive capacity and resiliency to stressors. And this picture on the right really talks about what we think of as a cumulative deficit frailty. And some propose that there is a cumulative deficit that arises from a variety of medical, social, and functional deficits that eventually lead to frailty. And importantly, I think it's really important to highlight that frailty may or may not be age-related. So some of these stressors that lead to frailty may or may not be due to age. And this figure really highlights that frailty coexists and overlaps with previous disability as well as chronic disease. And that when chronic disease includes cancer, patients are at an even higher risk of frailty. And that's why we see such high rates in our cancer patients. And so we really think of frailty as a state of extreme vulnerability to stressors that leads to adverse health outcomes. In reality, we know it's a much more complex physiologic, psychologic kind of issue. We think that approximately 50% of cancer patients are either considered pre-frail, so that means at risk, or frail. And some of this can actually start prior to your cancer journey or start to accumulate and occur during. And as I said, this typically is associated with older age patients, but younger patients can really experience frailty as well. And this is particularly seen in the context of cancer. So what impact does frailty have on our patients? In terms of specific oncologic or cancer-related issues, we know that frailty has significant impact on many dimensions. So this includes surgery. We've seen in many studies that frail patients have an increased rate of postoperative complications. This includes ICU admissions, increased hospital length of stay, readmission, and increased discharge to nursing home and facility. We also have seen in terms of chemotherapy, increased toxicity and decreased tolerance, as well as treatment delays. And we know that for frail patients, it can be very difficult to be involved in clinical trials and be enrolled for clinical trials because they may not always meet the inclusion criteria. And importantly, we've seen overall outcomes are also affected. So this means a reduced quality of life, a loss of independence. And in some studies has even been shown that frailty is associated with an increased disease progression and decreased survival. This table here really highlights something else that I want to talk about. And really outside of the context of cancer, there are multiple other general adverse health outcomes that also pose significant changes to function and quality of life for our frail patients. So this means our frail patients may also have an increased experience of falls, disabilities, cognitive decline, functional dependence, institutionalization, social withdrawal, and death. And this is even outside of the context of just cancer itself. So one of the questions we often then get asked is, how can we support our patients who experience frailty? And one of the first really important steps is really identifying frail patients. So the utilization of screening is really our first step. And one of the major issues we've seen with this is frailty screening is very complex and very wide-ranging. So there are various numbers of screening tools. This includes the Frail Scale, the Vulnerability Elder Survey, phenotypic frailty, the Modified Frailty Index, cancer-specific geriatric assessment, et cetera. There's a very long list of screening tools. And really the main issue is they're both underutilized and inconsistently used. So one clinic may use one form of screening, another clinic may or may not use a different form of screening. And there are obviously a number of various pros and cons to each of them. One of the major barriers that people cite to screening for frailty is really the time it takes to perform this testing, and also the ease of use of some of these screening tools. There are also some interesting studies looking at novel mechanisms to screen patients for frailty. So this includes CT scans that examine patients for sarcopenia, which is known as low muscle mass, biomarkers, which are blood tests that help us maybe determine who might be at risk based on some blood studies who are at risk or are frail. And there are also some studies looking at mobile apps to see if we can use smartphones to really track patients and see if they are at risk or experience signs of frailty. These are two screening tools that I just wanted to compare, and that's because they're different but are screening for the same thing. This is called the Frail scale, which I think of as more of a subjective scale. So it asks patients specific questions and asks them, do you experience some of these things, including fatigue, resistance or difficulty climbing stairs, ambulation, illness, and loss of weight. This is called phenotypic frailty, and this is what I consider a more objective score. So it really looks at specific measures that we can measure ourselves to look for weight loss, weakness, exhaustion, slow gait speed, and low activity. So as you can see, different forms of screening patients for frailty are very wide-ranging and different in terms of how time-intensive and how complicated they can be. The second step is really promoting pathways and multidisciplinary teams to improve surgical outcomes and the delivery of chemotherapy. And what we really think of this as is individualization of care. So once we've identified that someone is either pre-frail or frail, how can we individualize their care to really promote improved outcomes? So in terms of surgery, what people are proposing are using multidisciplinary pathways to really improve outcomes. And this is a review in one of our major oncology or cancer journals of how we can use 6 specific patient-centered changes in our surgical pathways here to improve functional outcomes. And really the end goal is something we call functional recovery, which really means outcomes that patients care about, such as function and independence. And so the 6 patient-centered moves are labeled here, 1 through 6, but it's really looking to see how can we improve different parts of surgery to improve outcomes. So increase utilization of minimally invasive surgery when appropriate, because we know patients recover much better from minimally invasive surgery when we use it. This also means using enhanced recovery pathways that a lot of hospitals are now utilizing to improve postoperative pain and increase speed to recovery. Other examples of how we can use this pathway are frailty screening, which we previously talked about, the use of rehabilitation, so strength training after surgery, and prehabilitation, strength training before surgery. And then the 6th step that they propose is improving social support for our patients after surgery. And as you can see, it involves a number of different providers, ranging from geriatrics to our medical and radiation oncologists, to our surgeons, to our anesthesiologists, to our physical and occupational therapists. And as well as our case managers and social workers. So this can be very complex and requires a lot of teamwork, but we know can also really help patients improve their functional outcomes at the end of surgery. In terms of chemotherapy, we know that a holistic and integrative approach has been shown to reduce serious chemotherapy toxicities. So this is a figure from a study that was published in one of our major cancer journals, where patients were randomly assigned to receive care from a multidisciplinary team that implemented the above kind of interventions versus just normal care. And they basically showed that when patients were assigned to receive this specialized multidisciplinary approach, using this holistic integrative approach, where patients were screened for the following deficits in all of these various domains, that patients actually were able to have reduced serious chemotherapy toxicities. So when we look at all these different areas that patients could potentially be affected by, they actually found that when they screened patients for all of these things and implemented these interventions, they were able to tolerate their chemotherapy better. And then the third kind of important part of helping our frail patients is really the early involvement of symptom management or palliative care. And the reason that we think of promoting palliative care is important is because we know that early referral and utilization has improved outcomes for frail patients. This is a nice figure that they actually published in one of our major cancer journals for providers, really kind of using a metaphor to describe the difference between a late palliative care referral and an early palliative care referral. And the analogy or metaphor that they're making here is that palliative care is much like an umbrella. It's really nice to have an umbrella ahead of time and ready when the storm comes. And patients are much happier when they have it and are glad when they had it available, versus not having the umbrella, getting soaked in the rain, and then having the umbrella after. So we often think of palliative care as a really important tool, because when we really need it, we're really happy we have it ahead of time. And so this was a metaphor that was published to really encourage our oncology providers to help our patients get an early palliative care referral. And some of the reasons why we recommend promoting palliative care or symptom management early on is because we've seen in many studies that patients have improved long-term outcomes. This means an improved quality of life, decreased psychological distress, improved end-of-life care, and have even been shown to have improved survival when they have an early referral. We've also seen that early referral to palliative care improves surgical outcomes and has been shown in many studies to reduce complications and death around the time of surgery for frail patients. And this really means ensuring patients and providers have the same goals of care, and also making sure that we have advanced care planning in place prior to surgery. These are some of the interventions that I just wanted to bring up that are either in progress or currently active at UCSF. One of the major things that we've done is the symptom management service has become very involved with our gynecologic oncology clinic. They've been promoting early and regular screening, and actually have hired a new provider that will work exclusively with just our GYN oncology patients and provide consultation services and close support. And I know that's something that Dr. Chen has worked very closely with our symptom management service on. Our geriatric team has also been closely involved with our clinic and has started to implement geriatric needs screening. And with this screening system, they basically recommend either referral to geriatrics or other services, such as social services, physical therapy, or anything else that's needed. And then the third program that I'm particularly working on is a prehabilitation program. So prior to surgery, optimizing nutrition and muscle mass and strength in preparation for surgery. So those are some of just kind of the active things that we're working on at UCSF, because we know that our frail patients will definitely do better if we implement interventions to help promote improved outcomes for these patients. I apologize, I haven't been monitoring the chat, but I will stop my screen sharing here and see if there are any questions or anything that people specifically want to address.
Thank you very much, Dr. Cham. I think that what we want to do is bring in a multidisciplinary approach to our patients perioperatively and postoperatively. And I think that developing the appropriate interventions is really what's going to make the difference. We've recognized for some time now that there are patients who are at higher risk, and we look to things that we can do to make their course easier. And as you said, get them back to their full recovery.